this is Dr. Michelle Clayman, and this is a presentation on take-home naloxone. I work at a few different places. One, I work at a community opioid clinic called True North Medical, and then I also work at St. Mike's Hospital as an emergency physician and an addiction medicine consultant. However, we have to remember that opioid overdose just does not affect people who abuse opioids. Think about the 80-year-old grandmother who takes a few extra Percocets on a Wednesday because her back pain is flaring up, or a child who gets into his mother's methadone dose in the fridge and overdoses an opioid. So even though these pictures are representative of some famous people, we have to start thinking about others who might be at risk for opioid overdose.
Dr. Michelle Clayman, consultant for the Ontario Pharmacists Association, naloxone training. Anyone can overdose. Guess it's a good idea for a family member to withhold the breath of life from grandma and torture her to death with chest compressions. Also a mother to kill her child. In section 3 on her training session, chest compressions only.
The patient is at risk for overdose once that naloxone wears off. So that's a lot to cover. I'm sure you're thinking, how are we going to teach our patients or our clients all these things in a very short period of time in the pharmacy? So you don't have to come up with these training materials on your own. Ontario will be coming up with some very shortly. I know the Ontario Pharmacy Association is working on the training materials. What we have right now to guide us is the training materials that have been used by Toronto Public Health. So this is an example of the card and poster that Toronto Public Health has.
They've taught tens of thousands of people that. They publish it in the bloody newspaper, those, to do that. Any doctors who misdiagnose respiratory emergency, they all appear the same. Die, respiratory arrest. There we go, the signs and symptoms.
Toronto Public Health has also produced this document outlining the signs of opioid overdose and recovery position. So they put some information here that helps remind patients what opioids are. So opioids include OxyContin, Oxyneo, fentanyl, heroin, Percocet, Dilaudid, codeine, morphine, and methadone. And again, naloxone only works for opioids. They've outlined the signs of opioid overdose. So you can't wake the person up. The breathing is very slow, erratic, or stopped. There's deep snoring or gurgling sounds. The fingernails or lips are blue or purple. Body is very limp, and the pupils are very small. They then recommend the recovery position. So they've recommended putting the patient in the recovery position if they are unconscious and breathing, or if they have to leave the patient unattended. These documents are available free of charge on the Toronto Public Health website.
All those signs prove the heart speeding could be any respiratory emergency patient. So when you train lay persons all those signs and symptoms, they're only too eager to do what a doctor tells them to do. Crazy. Crazy, crazy. They think they're saving lives. Doing the worst possible thing you can do. Here's what you're really supposed to do. Any breathing emergency, give them air. It's more important than the actual naloxone, because naloxone doesn't always work all the time. Yeah, could be dead by the time that starts working. Brain dead, lack of oxygen.
This is naloxone hydrochloride. We commonly refer to it as Narcan. It's used in opioid addiction or opioid overdoses, normally in people who are addicted. Heroin, some prescription narcotics overdoses. The way that it works, there's multiple different routes to go through, and we give it when someone's not breathing on their own. So if you do encounter someone in this before a paramedic's on scene, you're just going to provide rescue breaths either with a bag valve mask, mouth to mouth, or if you have a mouth barrier device to use issues. And then, like you said, multiple routes. A lot of times people with heroin addictions, they don't have good veins. So what I have screwed on here right now is our atomizer, and all we do when we're administering Narcan is we actually can just stick it up a nostril, and then we just push it right through there. And they usually get, you know, a dose in each nostril. And what we're doing, our main goal with it is not to bring them up right away. It's actually to get them to breathe on their own more normally. If we wake them up too soon, we can cause them to either become violent, they can vomit or have some sort of reaction that way. And we want to make sure that that airway is protected, because the big problem with narcotics is they're not breathing appropriately, and that's what's killing them. So our goal is to get them to breathing, and if you encounter someone and don't have Narcan, you just got to breathe for them.